Mass General will be live streaming and recording this presentation on social media. You'll see Mass General staff members filming in this area. Mass General staff are trained in patient safety and privacy. The staff will not interfere with the presentation. Patient questions can be written down and a member of the Blum Center will ask the question. If you have any questions, please talk to the Blum Center or Mass General marketing staff. Thank you. And today our featured speaker is Dr. Fatima Cody Stanford. Fatima Cody Stanford. She's a fellowship-trained obesity medicine doctor here at Mass General and at Harvard Medical School. She received her bachelor's and MPH from Emory University, her medical degree from the Medical College of Georgia School of Medicine, and her MPA from the Harvard Kennedy School of Government as a Zuckerman Fellow in the Harvard Center for Public Leadership. She completed her obesity medicine and nutrition fellowship at MGH and Harvard Medical School after completing her internal medicine and pediatrics residency at the University of South Carolina. She served as the Health Communications Fellow at the CDC and a Behavioral Sciences intern at the American Cancer Society.
Well, good afternoon, everyone. You're supposed to respond. Good afternoon. Okay, you guys, we're gonna wake you guys up. So today we're gonna talk about understanding optimal weight and nutrition in children and adolescents. We're gonna go over quite a bit, and we'll go over that on the next slide. So here are our 5 objectives for today. We're going to describe the epidemiology and prevalence of overweight and obesity within the pediatric population, specifically focused here in the United States. We'll relate chronic disease risk factors in the pediatric populations to the presence of overweight and obesity. Then we'll discuss the persistence of chronic disease risk factors and weight bias, how it presents in childhood and adolescence and what that happens in adulthood. We'll explain the pathophysiology of overweight and obesity, and finally, we'll evaluate the genetic components in the prevalence and development of pediatric overweight and obesity. So first, I'd like to look at obesity as a disease, and what I really want to do is capture how prevalent it is, and this is based upon actually 2012 estimates, so you can say that this is probably a bit more pronounced, but this is the prevalence of different disease processes here in the United States in millions. So what you can see here at the bottom is we have all cancers, about 13.8 million individuals, diabetes, 37.2 million individuals, non-alcoholic fatty liver disease, 80.3 million, and when we get into the prevalence of adults with obesity, we have 93.3 million adults with obesity, which is approximately 40% of the US adult population. Now, I thought I put a few people up here or other things that really aren't disease processes, but just to give you a sheer understanding of the volume of persons that have obesity here in the United States, you can see that 115.6 million persons own a TV, and in terms of those that own a smartphone, a little bit over 200 million individuals here in the United States. So the reason why I devoted my life to the care of patients with overweight and obesity is due to the sheer volume of persons that are affected by this disease process here in the United States and abroad. So there are a few questions that I want us to kind of think about, and we don't have to have the answers now, but I will revisit these questions at the conclusion of this presentation. So question 1, I want you to think about and kind of, think about it in your head. So the most recent data indicate that X% of US children and adolescents have obesity, and that's specifically here in the United States. Do you believe it to be about 9% of children and adolescents here in the US with obesity? About 19% of the population, specifically for children and adolescents here. About 25%, which is C, or finally about 33%. So I just want you to think about that. We will come across that as we discuss the content for today's presentation. So let's go to our second question. What is the average age in which children begin to demonstrate signs of weight bias? So what age is it? Is it 12 months of age? Is it 20 months of age? 32 months of age? Or 48 months of age? So keep in mind, these are all very, this is all, a child is very young, but what age do we begin to see weight bias being demonstrated within children? And finally, our third question, which we will capture throughout the course of this presentation today, is weight stigma has not is really key here, has not been associated with which of the following? Is it A, disordered eating, B, metabolic syndrome, C, elevated blood pressure, D, high triglycerides, which is a type of cholesterol, or E, low HDL. HDL is a type of cholesterol. This is the one that's the good cholesterol, just to give you some perspective. So throughout the presentation, I want you to be thinking about these questions. We'll capture them, and hopefully by the end of the presentation, you will have answers to these questions. So let's talk about obesity prevalence by age group, and we're focusing here on children and adolescents. And we're going to look at the most recent data out of the CDC and the National Center for Health Statistics from 2015 to 2016. What you'll see here in this column is the total, so that's all, and then we have this separated out by boys and girls. But what I want to show you here is about 18.5% of the US population between the ages of 2 and 19 actually have the disease of obesity. I'm being very thoughtful in my choice of words. Notice I have not called anyone an obese person, right? They have the disease of obesity. It is important for us to think about the language we use when we're talking about the disease of obesity. Labeling someone as an obese person is categorizing them by their disease process rather than acknowledging that they have that disease process. It's considered inflammatory. I've written and published on this in JAMA Pediatrics just as of November of last year, but I think we need to be very thoughtful and mindful about our choice of words, acknowledging that these 18.5% of children and adolescents actually have this disease of obesity. So that's important. What you can see also in this particular graph is that we have different age categorizations. Between the ages of 2 and 5, you can see we have a little bit lower prevalence of obesity. And as we climb up into those higher age categories, we see that the prevalences of obesity do cross the 20 percentile. So that's important for us to recognize. Now, how does this break down by race and ethnicity? What we do know is that there are disparities when we look at the prevalence of overweight and obesity in non-Hispanic whites versus non-Hispanic blacks, and Hispanic specifically. So this is also taken from NHANES, which is the National Health and Nutrition Examination Survey. So this is actual measured data out of the CDC. And what you can look here is I want us to focus on the differences in prevalence. For example, if we look at the total prevalence, which I'm going to focus on, you can see that non-Hispanic whites, about 14.1%, have the disease of obesity, whereas non-Hispanic blacks, we see 22%. We see a drop-off in the Asian cutoffs to 11%, and then for Hispanics here in the United States that fall within this age range, and you can see that that's the age range of adolescents, 25.8%. There are differences, as you can see, between boys and girls, with Hispanic boys having the highest prevalence of obesity in all of the groups that are categorized here. And let's look at our obesity epidemiology, and we're not taking this back very far. Sometimes I will start my presentations taking the data back to the late 70s or even early 80s. We're starting in 2000, so just 19 years ago. And what we can see is the prevalence of obesity in adults, which is that top blue line, has risen to about 40%, whereas the prevalence of obesity within youth has climbed to 18.5%. Now I want to take some time to talk about the prevalence, and these particular graphs that you're going to see now do actually focus on the adult data. They do not have these lovely graphs or charts available, unfortunately, for the pediatric data, but I think it's important for us to just look starting at 2011 from the BRFSS, which is the Behavioral Risk Factor Surveillance System, and why I think it's important for me to tell you where this is coming from. As opposed to NHANES data, this is self-report data. And the reason why this is important is because I want you to think about your driver's license and whether or not you self-report your actual weight and whether that's been updated appropriately as you've aged, maybe. So this data is probably underreporting the prevalence of obesity by state and territory in the United States. If we look at the colors of this graph, it's important for us to note that there is no state that has less than 20% of obesity by self-report data. When we get into the green, we're getting into prevalence of obesity within that state of 20 to 25%, yellow 25 to 30%, and orange is 30 to less than 35. I call it crimsoning of the map. We're here at Harvard, so greater than or equal to 35 being considered actually not a great thing here, but let's look at what happens when we go from 2011 to 2015. very quickly what we'll see is that these numbers do change. So let's look at 2015, keeping in mind that we're in 2019. This is the most recent data out of the CDC, and we see this crimsoning of the map, right? We see states like West Virginia, Mississippi, Alabama, and Louisiana now having prevalence with self-report data of greater than 35% of obesity within their state. Now, we talked about those racial and ethnic differences, and I want to take a peek at this in the adult population, much like we did in the pediatric population. So what we can see here is that in that same cohort of data, that if you are a non-Hispanic white adult and you live in Colorado, for example, that there's a lesser likelihood of having obesity within that state, and also out here in DC and Hawaii, if you see here at the bottom. We can see that West Virginia and Puerto Rico, if you're a non-Hispanic white adult, that the prevalence of obesity is still very high within those locales. So let's shift to looking at Hispanic adults, and let's look at how that map does change. We see a significant shift, and we have a larger presence of overweight, specifically overweight and obesity, greater than 35% noticed in those red or crimson areas. But what really brought me to this work was this final graph that we're going to look at, looking at demographics. And this is the self-reported obesity among non-Hispanic blacks here in the United States. And what you can see here is almost a complete crimsoning of the map. As an African-American woman, I was drawn to this work way before, obviously, 2013 happened, but I could tell that there was a difference in the prevalence of obesity within the African-American population, and I wanted to be invested in treating this disease process, specifically in this patient population. Now, when we look at how we discern weight and weight regulation, what we typically use is BMI, or body mass index, and there are some flaws with the use of BMI because it just takes into account height and weight. But we don't know much about that weight. Is that weight muscle? Is it liquid? If someone has heart failure, their weight may go up if they haven't gained fat or adipose tissue. And so BMI is what the World Health Organization utilizes, but we do recognize that it comes with some flaws. Now, we're going to look at how obesity is defined within children and adolescents, which does differ from how it's defined in adults. And this is based upon the BMI percentile range on those growth charts. So it's important for us to recognize that we cannot look at the same percentiles for ourselves as we do for children and adolescents 20 and under. So what you can see here is that if you're less than the 5th percentile, that's considered to be underweight. If you're between the 5th and 85th percentile, that is considered to be of healthy weight. A person has overweight if they're between the 85th and less than the 95th percentile, and they have obesity if they're greater than or equal to the 95th percentile. Now let's look at how that differs when we look at our weight status as adults, the people that are probably looking at this, although I wouldn't be surprised if we have some really talented children and adolescents viewing this. You can see that this differs quite a bit. So when we're looking at underweight status, a BMI less than or equal to 18.5 is considered to be underweight. Normal weight status between a BMI of 18.5 and 24.9. And we have overweight from a BMI of 25 to 29.9. Now there are 3 classes of obesity: mild, moderate, and severe, or class 1, class 2, and class 3 obesity. Mild obesity being characterized by a BMI of 30 to 34.9, moderate obesity being classified as a BMI of 35 to 39.9, and those that have severe, not morbid, we will never use the word morbid because it's also inflammatory language and we use it with no other disease process, but those that have severe obesity have BMIs that are greater than or equal to 40. Now we talked about this being a focus on children and adolescents, so I will be remiss not to pull up the pediatric growth chart, which is how we determine obesity within the pediatric population. What you'll see here is that the age goes from 2 to 20 years of age, and we have percentiles. What you also see is this lovely red, yellow, and green. So green being good, yellow being caution, and then red being not the area we would prefer to be in. So let's look at a 10-year-old boy that has a BMI of 13. You can see that he falls down here at the bottom and would be considered underweight. So we don't want that either. We want to be in this kind of healthy, broad category that you can see here. We have a 10-year-old boy with a BMI of 18. That would be considered a healthy weight. Now, when we cross into this person that's here, another 10-year-old boy that has a BMI of 21, If you'll recall from our adult data, BMI of 21 is considered normal within the adult population. But as we chart it out here on the growth chart, you can see that that falls into the overweight category for this 10-year-old boy. Similarly, when we look at this 10-year-old boy that has a BMI of 23, that would also be considered normal for the adult population, but it falls into the obesity range when plotted out on the growth chart. So these growth charts are very important within the subset of looking at this within your pediatrician's or your family physician's office with your child, your adolescent. Now let's look at why it's important to consider weight maintenance, for example, within this population. Let's say we have that same 10-year-old boy that was considered to have obesity in that previous slide. So he has a BMI of 23. If we can help him maintain his weight at that area, when he gets all the way to 15, that's 5 years later, you can see that he falls within the normal weight or healthy weight category. So weight maintenance, not necessarily weight loss, in a patient that falls within that realm would be advantageous for now this 15-year-old boy who is considered to have a healthy weight. Now, what I want you to do is I want you to put on your thinking caps, and I want you to understand that maybe visual inspection isn't so great in helping us to identify obesity within a population. So what I want you to do is I want you to look at this 4-year-old girl, and yes, this was taken back from the 70s, but it doesn't look too dated. And so I want you to look at her, and I want you to decide what weight category she might fall in just by visual inspection. And you guys can raise your hand. Do you feel as though she falls in the A category, which is she's considered to have underweight? Do you think that she falls there? You raise your hand. Do you believe she falls in the healthy weight category, so between the 5th and less than the 85th percentiles? How many people think that? Okay, so a couple of hands there. What about persons thinking that she falls between the 85th and less than 95th percentile, which would be considered as having overweight? And then finally, our final category of D, which is those that have obesity, how many people feel like she falls within that category? Okay, so nobody really believes that. You guys were kind of between B and C. So let's see where she plots out. So this is our young 4-year-old girl. She's plotting out. We have her height, her weight, her BMI, which looks great if it were an adult, right? Or actually too low. But she actually falls within the overweight category. So this shows us how visual inspection doesn't serve us well when we're really trying to ascertain if someone like this young girl has the disease of obesity, but she is characterized as having overweight. So let's do another example to see how this plays out. So we have this 3-year-old boy, and we're going to do the same exact experiment as we did previously. How many believe that he has underweight? That's A. What about how many believe that it's B, which is that healthy weight category? Okay, so a few hands there. What about those that feel as though he falls within the overweight category? Okay, so maybe a few hands there also. And then how many people feel as though he has obesity? Okay, so a few hands there. Notice we had a spread of persons in terms of their response. So here we go, we plot it out, we calculate it. Remember that BMI not giving us much information, we have to do the plot. And what we find for this lovely young boy is that he actually falls into the category of having obesity. So we need to utilize these tools to really help inform us what we need to be doing as we look at persons that have this disease of obesity. Now, unfortunately, when we've talked about or learned about weight and weight regulation, and that is within the lay population for those watching and in the medical community, we learn very little about obesity. We learned that it's very simple. It's all about calories in and calories out, how much food and beverage you take in, and how much bodily functions, your physical activity, stool output, etc. And if we could just get that under control, then we will help regulate our weight and we should be fine. Well, I'm here to tell you that that is indeed inaccurate. And if we continue to follow this mantra, we will continue to see a rise in obesity as we don't tackle the complexity of this disease process. We'll learn a little bit about this complexity in just a few moments here. So we're going to start at like the kindergarten level of thought process. We're going to graduate to a PhD in this disease process, and then we'll bring it back down to 8th grade to make sure that everyone is with me. So first of all calories are not created equal. So I want you to look at the left side of my screen. We have a slice of pepperoni pizza on the order of about 350 calories. And on the right side of the screen, we have this much Imagine it's a much larger dinner plate of quinoa, chickpeas, roasted red peppers, etc. About 700 calories. So should I just eat what's on the left side of the screen? I just told you it was 350 calories, and what on the right side of the screen is 700 calories. What should I do, you guys? Should I eat this? What do you guys think? No. Why not? Because the quality of the diet is very different, and our brains actually respond to the quality of our diet. Now, does that mean that everyone that eats a healthy diet will be lean? Absolutely not, and we'll delve into that a few moments, but we do want to maximize the quality of one's diet from early age because it does affect how the brain regulates weight. So what we've learned is that obesity is a multifactorial disorder where genetics, environment, development, and behavior all play a role in a person's likelihood of having obesity. So here we go, we're in that PhD level. We start in kindergarten, but this is very important for us to recognize the role of the brain in regulating weight. So here we have the hypothalamus. The hypothalamus is really centrally located in the brain, and the hypothalamus is getting signals from our fat tissue, which is out here, so there's a hormone called leptin there. It's getting signals from our large intestine, small intestine, our pancreas, and our stomach. And it's sending signals back via the spinal and vagus nerves to our brain to tell us not only how much to eat, it also tells us how much to store. So let's think of this as kind of 2 lanes down a highway that you might go. And maybe we're going through 2 different toll booths. And we're going to call this the toll booth on the right, and this the toll booth on the left. And we're looking at leptin, which is a hormone that signals from fat cells. Now, if we go down this toll booth on the right, this is kind of the speedy lane. This is the one we want to be in if we want to get where we need to go. Leptin binds to this receptor. You don't have to remember this. I won't test you afterwards, I promise. But this neuron, a neuron communicates information. It's called the POMC, or the pro-opiomelanocortin neuron, fires in the brain. And when that fires, it sends an anorexigenic signal to our brain, which tells us not only to decrease our food intake, it tells us to decrease our food storage. So persons that signal down this side of the pathway, that kind of speedy pathway, tend to be very, very lean. And that's great for them. My husband is one of those individuals, and for 25 years I've had to acknowledge and deal with that. That's great for him. My patients don't signal very well down this side of the brain. They signal down the alternate. This is that lane that you're like, gosh, I can't believe I ended up in this toll lane. And what happens is a different neuron fires in the brain. This is called the AGRP, or the agouti-related peptide neuron. When this fires, it sends an orexigenic signal to the brain. Orexigenic is the opposite of anorexigenic. And when we signal down this pathway, not only might we eat more, we store more. So this is those patients that, you or your friends or family, you talk to them and they're doing whatever they can to really look at their intake, their quality, and no matter what they do, they always seem to gain. And we often put blame on them, which I want us to not do, because they're just signaling in a different pathway. So we're bringing it back down to 8th grade, because I know that was kind of getting a little complex there. So we're going to bring it down. We have the brain, right? So the brain is getting signals about our diet quality. I do not ask my patients ever about the number of calories they're eating. I do not care. I do care about it looking like this. We want lean protein, whole grains, fruits, and vegetables to be predominant within one's diet. Now, physical activity is huge, and I am a huge advocate of physical activity, but I think we must understand the role it plays in regulating weight. When we're looking at someone that's physically active, let's say they've been physically active for the last 10 years or so, what we expect is weight maintenance. But what happens on January 1 everywhere in the United States and around the world? People go join gyms to do what, you guys? To lose weight, right? And when they don't lose weight by February 1st, or maybe even March 1st, if they make it that far, they leave the gym. Because the wrong message is being sold to them by the persons at the gym, by our culture, which is that physical activity leads to loss. On average, it leads to weight maintenance. So what happens is, let's say you have a person that has obesity, that has gained 5 pounds every year for the last 10 years. So they have an excess of 50 pounds from their baseline. Their physical activity can help quell that increase, And so we want patients to be physically active because it's not just about weight, right? It improves our heart status, it improves our depression, or likelihood of having depression or anxiety. Very important, but I think it's important for us to acknowledge the actual role that physical activity plays in weight regulation. Now, sleep quality and duration is also very important. And what we want to do is we want to maximize sleep quality and duration, or we may struggle with weight without regulating this. What we do know is that sleep, which also affects the brain and also interferes with those pathways we talked about, if it's not optimized, it can cause more of a promotion down that orexigenic or weight promoting pathway. Now, when we look at medications that we as doctors prescribe to patients are the culprit of a lot of weight gain here in the United States and around the world. Medications like lithium, Depakote, Tegretol, Celexa, Cymbalta, Effexor, Paxil, Prozac, Ambien, Trazodone, Lunesta, gabapentin, glyburide, glipizide, glimepiride, long-term insulin, prednisone, just to name a few, are drugs that can cause pronounced weight gain. And so what we as healthcare providers, physicians need to be aware of is that we need to help reduce the incidence of drugs that are being prescribed that are causing our patients to struggle with their weight. If we can find an alternative agent, that would be most ideal. Now, this looks like another person sleeping. You're like, well, Dr. Stanford, you already talked about sleep, but the difference here is that they're sleeping during the daytime. And so circadian rhythm disturbances also affect the brain and how the brain regulates weight. So what we need to know is that the brain likes to be awake when it's bright outside like it is now, and it likes to be asleep when it's dark outside. And when we have to twist that, which often we have to do in healthcare and other industries, that can affect our weight without any other changes. And then finally, thermogenesis, which is just how much our body's burning at rest and with activity. A lot of that's genetic in nature. That plays a large role in how we regulate our weight. So let's look at how complex this is. And you guys were probably wondering, why is it not just about calories in and calories out? Because of this lovely chart. So what we know is that these are the potential contributors to obesity. And I know it's a lot up on the slide. We'll come and just pull out a few of these. But what you can see is that there are obesity contributors that happen inside of a person. And on the right side, there are things that happen outside of a person. Things at the top here increase someone's intake. These things here decrease how much one's able to burn. And here in the middle, these things affect either intake or expenditure, or we haven't quite figured it out yet. So you can see there's or unknown. These are contributors and influencers to weight. So these colors mean something in the context of this figure. Environmental pressures on physical activity, mostly concentrated here. They decrease the ability to burn. Biological or medical reasons why someone may struggle with weight in the lavender color. They are kind of all over. You can see inside and outside of the individual. Maternal or developmental factors that may affect weight, which we'll talk about in just a moment. Those are contributors to intake and expenditure. The only things we really ever hear about in our society and in medicine, unfortunately, are the things here in pink and orange, which are economic reasons why someone may struggle with weight, and food and beverage behavior and environment. Finally, we have psychological reasons why someone may struggle with weight, and then social reasons. I told you I'd pull out a few of these because I know that's hard to read with just how many issues that we have. Those were the contributors and influences that I just talked about. But let's look at a few of these to just get a sense of what is falling in these categories. So we're talking about contributors to obesity inside of the person. Things that increase intake might be hyperreactivity to environmental food cues, delayed satiety, meaning how long it takes you to feel full, and disordered eating. Things that might decrease your expenditure are your gut microbiota. So that's the bacteria in one's gut. And what we know is that for persons that are very lean, they have different types of bacteria in their gut versus persons that have obesity. Thermogenesis, which we talked about a little bit earlier, how much we're burning at rest and with activity, and physical disabilities might decrease one's expenditure. Things that might increase intake and decrease expenditure are genetic and epigenetic factors. These are huge. Age-related changes, and for women, this is most important. So as we age, especially as we hit menopause, we do see significant shifts in weight. We see a distribution of fat that changes from a gynoid distribution, which is in the hip, buttock, and thigh region, to more central region, what we call android deposition of fat, here in the more central region. And then mood disturbances, that might increase intake or decrease expenditure. Now, things that happen outside of the individual, so exterior to ourselves, that might increase intake or environmental chemical toxins. Maybe we just have a lot of food advertising in large portion sizes. Things that might decrease expenditure, our built environment, our amount of sedentary time, labor-saving devices like washing machine or dryer, for example, and things that might increase intake or decrease expenditure or weight bias and stigma, which we'll spend a little bit of time talking about. Weight cycling, meaning people go on all of these diets to try to lose weight, and what they do is they lose weight and then they always gain more because weight cycling likes to defend a higher set point for weight. And then maternal or paternal obesity, meaning if your mom and father have obesity as a disease. Now, I told you I wanted to talk a little bit about sleep, and I think this is by far the best study that's been done looking at the long-term impact of childhood sleep on obesity. And this is what we call a prospective study. What we mean prospective is it starts at time 0, and this started at 3 years of age, and they followed these persons all the way to the age of 32. So quite a big time investment for these investigators. But what you can see is that there are a few things that they're looking at. They're looking at short sleepers, which are here in this kind of black dot, moderate sleepers and long, which may be hard to distinguish. But you can see that over the years, those that are short sleepers did have higher levels of obesity compared to those that were both moderate and long sleepers. What we also know is that the moderate were actually below here. I know it's hard to see. So those moderate, those ones that are in the middle, not too long or not too short, had the lowest weight status over 32 years. And this was a large sample size. So you can see that it has a significant impact on weight status, optimizing sleep. But I think one thing that we don't spend a lot of time talking about is this idea of fetal programming, which means that if a mother goes into pregnancy with overweight and obesity, her child, without looking at the genetics, is predisposed to having obesity and obesity comorbid conditions. So we have a mom that has obesity. She has increased inflammation. She has increased insulin resistance. She has an increased breakdown of cholesterol and increase in inflammatory markers, which then exposes the fetus to these lipids, which is cholesterol. And when that fetus is exposed, it leads to an increased risk of childhood disease, specifically fatty liver disease, insulin resistance, obesity, hyperphagia, which means a desire to eat quite a bit, and type 2 diabetes. So how might you modify this in patients that have obesity preconception? There was a lovely study that was published in the Journal of Clinical Endocrinology and Metabolism, which looked at children born to mothers before they had weight loss surgery and looked at the second sibling that was born after weight loss surgery. So this BMS stands for before maternal surgery, AMS stands for after maternal surgery, and we're going to just compare and contrast these values from the older sibling to the younger sibling. Same genetic makeup from both genetic parents. But what we can see is that the weights of those born after surgery were lower. Macrosomia, which means having a baby that's born with a big body, was less. Obviously, they were younger, right, because they were born after surgery. The body mass index was lower. The weight's lower. The body fat percentage is lower. The insulin is lower. And their glucose is lower, consistently across the board. So we've modified significantly that child, despite the fact that they have the genetics of having a predisposition to obesity, we've modified them. So what we see is a 3-fold decrease in the prevalence of severe obesity in these children that are born after surgery, increased insulin sensitivity, improved lipid profile, a decrease in CRP, which is an inflammatory marker, increase in leptin, decrease in ghrelin. And so this is an important target for public health. What we need to do is modify moms and dads' preconception to really have the biggest impact on the weight status of the offspring. So let's look at environmental factors in obesity. So there can be an environmental influence on weight, and I won't downplay that, but different parts of our community play a role. Schools and childcare settings, the family and community, our media and entertainment industry, our food and beverage industries. I feel like they get all of the brunt of this, but all of these have a role. And then faith-based institutions and government agencies. These affect the environmental factors and its influence on weight for our children and adolescents. So why care? I said obesity is a disease. Maybe you're convinced, maybe you're not. But if you aren't convinced about obesity as a disease, which I hope I've convinced you of, let's look at how it affects every major system in the body. And we're focusing on the psychosocial. We see poor self-esteem, depression, and eating disorder in persons with obesity. We have neurological conditions. This is called pseudotumor cerebri that happens solely because of someone having excess weight. We have cardiovascular issues, problems with cholesterol, high blood pressure, inflammation. We see sleep apnea, asthma, GI issues where we have gallstones or fatty liver. Fatty liver is becoming the #1 reason for liver transplants here in the United States. We have problems in the kidney. We have endocrine problems, type 2 diabetes, polycystic ovarian syndrome. Boys that have obesity don't develop gonads as well, so they have hypogonadism. And then musculoskeletal, we have different issues like a SCFE, which is a slip cap femoral epiphysis, Blount's disease. So really every major system of the body is impacted, and these are specifically pediatric diagnoses. I didn't present the adult data here, but this shows you the prominent impact of obesity on the pediatric population. So what do? So the American Academy of Pediatrics has come up with this 5-2-1-0, which means 5 or more fruits or vegetables a day, 2 hours or less of recreational screen time. So recreational is important there. So we want to keep the TV and computer out of the bedroom. That's also the iPad, iPhone, etc. 1 hour or more of physical activity is the recommendation for adolescents and children. And 0 sugary drinks is the recommendation. So that's what we want to think about. And when we're thinking about what to do if our child or our family member or our friends struggle with obesity, is that we have a 4-staged approach for dealing with this issue within the setting of the clinical setting. We have that stage 1, which is that prevention plus, really trying to prevent our children from developing overweight and obesity. And you can see that that prevention plus happens in the primary care office. Then we get into stage 2, which is structured weight management. So maybe we're starting to struggle with weight, maybe we have overweight, and we have office support with a dietitian involved and family visits that can help with a child that is struggling with their weight. We can graduate to stage 3 if we have more significant issues, where we have a comprehensive multidisciplinary intervention, where we might have a doctor, a dietitian, a behavioral counselor, and an exercise specialist in the center. And then finally, you might consider tertiary care, which we have here at Mass General at the Weight Center, where you might entertain medications, very low calorie diets, or weight loss surgery. We perform surgery as early as 13 here at MGH, recognizing that early intervention decreases our likelihood of chronic disease. Of note, our average body mass index for a child or adolescent that undergoes surgery here at our center is 10 points higher at an average BMI of 53 compared to our adult patients, which has a BMI of about 43 at the time of surgery. So it shows you that the times that by the time they're intervened with, they have a much higher degree of obesity in the pediatric population compared to the adult population. So let's take a twist to bias, and bias is very important because bias does have a role in health outcomes. So the most common form of bias in our society has been race bias, and unfortunately, if you did a search for Black males that were teens in Google in 2016, so not very long ago, you were returned with these mugshots of young Black boys. If you did a similar search for non-Hispanic whites, you got these kind of lovely pictures where everybody is smiling. And race bias is still very prevalent, but what's becoming the most common form of bias is weight bias. And so when you look at this picture here, taken from Glamour back in 2012, there's certain adjectives that we associate with lean individuals versus those that have obesity. You can see a lean individual, we might see vain, or superficial, ambitious, or confident, mean. For those that have obesity, giving, insecure, undisciplined, passive, nice. And so we make assumptions about a person solely on either race or weight, and many of these things don't have much basis. So let's look at it. Why do we care? Does this really matter in the pediatric population? Let's look at this study that came out in 2016 looking at toddlers. So what they did was they looked at mothers and children, and they found that older infants had a bias for looking at figures that had obesity, much like these figures. But once they got a little bit older, about 32 months of age, they instead preferred looking at leaner individuals. And these toddlers' preference was associated with their maternal, meaning their moms, anti-fat attitudes. Many of the moms had significant bias as tested by questionnaires. We started to see the children have similar biases, and they pick this up very early in life, as you can see. And when we looked at it in terms of like parents, so we're looking at parents and not just the mom specifically, and they looked at specifically 3-year-old children, and they looked at 279, and they had the parents complete basically a questionnaire looking at body size, attitudes, and dieting measures. They interviewed the children, but what they found was that over time, negative attitudes towards large bodies and awareness of weight loss strategies were specifically predicated on the parents having negative attitudes in that direction. So let's look at kids, right? We talked about early kids, but let's look at kind of a prospective study. Those are always the best studies. And this study looked at whether weight-based teasing in adolescents predict adverse eating and weight-related outcomes 15 years later. So they also wanted to look at the teasing source. If you're being teased by either your peers or your family, how does that affect your outcomes? So this looked at almost 2,000 individuals, you can see, from 1999 to 2015, and it was in a diverse group of adolescents. And what they found was the following, that women or young girls that became adults, that they were affected by both peer and family-based teasing, while males tended to be affected by peer-based teasing. But regardless of this, it led to increased BMI, binge eating, dieting and unhealthy weight control, and body image issues, which was quite important. So this does have an impact on these children that become adults when we tease them about their weight. So why does this matter? Weight stigma matters because it causes stress. And when it leads to stress, it leads to issues like eating and physical activity behaviors such as maladaptive weight control, less physical activity, and lower motivation for exercise. It actually causes physiologic reactivity. So we see an increased level of cortisol and C-reactive protein, which are signs of inflammation. We have an increase in blood sugar. We have elevated blood pressure. And then patients don't want to seek us as healthcare providers because they feel as though we're not being supportive. That then leads to weight gain, which then causes depression, anxiety. We see high levels of substance abuse and suicidality. And then we see poor glycemic control, which just means blood sugar control, and more advanced and poorly controlled chronic disease process. So what happens outside of healthcare? Does this matter? Well, absolutely it matters. What they did was they looked at weight bias in graduate school admissions. So we want our kids to go on and do higher education. But what happens if they have excess BMI? So a higher BMI significantly predicted fewer post-interview offers from admissions programs and psychology programs such as the institutions that you see represented here. And this was much more important for female applicants compared to male applicants. Now, which we did see, or what they saw in particular, was that higher BMI was correlated with more positive adjectives in the letter, almost as if to compensate for the applicant's weight status. And then how does this affect hiring? So what they did was they looked at individuals. So this is the same young woman. She had obesity here. You can see that she's lost weight. And what they did was they said, hey, you know, this person has lost weight, and they rated their image of her, saying that, oh, she had been able to conquer this. When they went back and actually talked to the individuals and asked them again, are you excited about hiring this person if they used weight loss surgery versus diet and exercise, they no longer found them to be a desirable candidate, which shows our bias towards the use of weight loss surgery, which is often a tool for persons that have moderate to severe obesity, like this young woman. And then finally, let's get to The Biggest Loser, which is a popular show, and what it really does to influence weight bias. So in this study, they looked at persons and they assigned them to one of two groups. The experimental group, which watched an episode of The Biggest Loser, and another group which watched a nature reality show on maybe National Geographic. And what they found was that when they looked at these major tests, the implicit association test, which you can take for free under the Harvard IAT for weight, or a Harvard implicit association test, the obese person trait survey, and the anti-fat attitude scale, was just that after one episode of viewing, that persons that watched The Biggest Loser condition had a significantly higher dislike of individuals with overweight compared to those that watched the nature show. So let's revisit these questions, and I'll answer some questions. I want you guys to tell me what the most recent data indicate percentage of U.S. children. You guys should have gleaned that about 19%, or actually 18.5%, of adolescents have obesity here in the United States. The second question was, what is the average age in which children begin to demonstrate signs of weight bias? And that was 32 months of age. So very early in life that they begin to experience weight bias. And then finally, our last question was, weight stigma has not been associated with which of the following? And that was low HDL. It was associated with all of the above: disordered eating, metabolic syndrome, elevated blood pressure, and high triglycerides. So this is our summary. Obesity is the most prevalent chronic disease in both the adult and pediatric populations here in the United States, and that the etiology of obesity is indeed complex and often requires a multidisciplinary approach. We want a staged treatment approach for patients with obesity within the pediatric population, and weight stigma and bias does have a negative impact on the health and psychological health of patients who struggle with obesity. And weight bias can be seen as early as infancy and is strongly influenced by parents and their thoughts about persons that have overweight and obesity. And that's what that next statement is. So I want to conclude. I want to thank you for your time. I want to entertain any questions that you might have regarding what I shared, or maybe some things that are of interest, and I'd be happy to answer those questions for you. That means I did a good job. That's what that means. Or are you just like, I don't know what she's talking about? One of the two. Any questions for you, Marie?
No.
Okay, excellent. Well, I will stay around for a few minutes and answer questions. I want to thank you for your time and attention. Hopefully you have a better understanding of how we think about weight and weight regulation, the complexity of this disease process, and how we need to remove a lot of the blame from the patients that do struggle and just help them achieve the happiest, healthy weight for themselves. Thank you.
Thank you.